ECAB is a project funded by the European Commission that seeks to understand the practical challenges in enabling patients to cross border to receive healthcare within Europe. There are a number of examples of where health authorities in border regions have worked together to combine services. Often we find within Europe that the border areas are sparsely populated. So it may be much easier for someone to go to a hospital in a country across the border rather than within their own country. The health authorities have worked together to find ways to make that work. In the ECAB project, we are trying to go beyond those individual projects. We're trying to look at some of the issues that arise when people travel perhaps further. We've been looking, for example, at the very complex arrangements that have been put in place by the Veneto region of Italy, the area around Venice, who have a very large number of tourists coming in every year, and they've provided special facilities for people who have kidney failure, people who require regular dialysis. Now, the European Union has long had provisions to allow people with kidney failure to travel across Europe, but of course you need to make that a reality. If you didn't have those arrangements, those people would be excluded from the freedom of movement that everybody else is entitled to. So there are many of these, there are the cross-border projects that have worked very well. There are the longer range ones where tourists are travelling. And we've also looked at the situation in some of the smaller countries that perhaps are unable to provide all of the services that they might need, simply because there aren't enough patients to support those. Malta, for example, that for many years has sent patients to the United Kingdom where they require particularly complex treatment.
So every healthcare system has a defined set of benefits that you're entitled to. So that's what we call the benefit package. And if they seek healthcare, so a type of treatment that is outside that benefit package, they cannot expect to have the right to seek it abroad, and that means out-of-pocket payment. Now, under EU legislation, patients, EU citizens have different rights. So you can go to your health insurer or your health authorities and ask for an authorization to go abroad. And if there are, for example, very big delays in your home system, or if there's a specific type of treatment that cannot be provided in your healthcare system because it might be a very small, you live in a small country, so if you live in a country with 200,000 people, that healthcare system will not be able to provide very specialized treatments, and it makes more sense for the healthcare system to send you abroad. There is also another mechanism, another legal mechanism in the EU, where the patient can choose to go abroad, pay out of pocket, and claim reimbursement when the patient comes back home. And there's also a very specific set of rules when that reimbursement has to be given by the home country. And that's, for example, if there are substantial delays in the home system, the home country will then have to, under EU law, reimburse. But this is very new, this very recent legislation. So we have to see, it comes into force in October 2013, so we will have to see what will happen in practice.
The Evaluation of Care Across Borders project wanted to look at patient care pathways in more detail for healthcare services that are in place between different countries. And we identified a number of examples that we could learn from. And the Malta-UK cross-border collaboration is one of the longest standing examples. And so we wanted to look at it in more detail. So what we decided to do was to talk to policymakers, talk to health professionals, both in Malta and the UK, and talk to patients to try and understand how, try and understand the patient care pathway in more detail and how it impacted on health professionals and patients. Malta and the UK have a cross-border collaboration that has existed for over 30 years. The first agreement is a reciprocal agreement that was set up in 1975, and it's there to facilitate access to specialised care services for patients who have very rare diseases. So Malta is a very small country. It's a tiny island in the middle of the Mediterranean Sea, population of around 450,000. And when you have patients with rare diseases, it's very hard as a small country with limited resource to provide specialist care for them. Since 1975, there's been an agreement with the UK, which includes over 25 centres for excellence in the UK, whereby patients from Malta are sent overseas, are referred for treatment overseas in several centres in the UK. All of the people we spoke with, the health professionals and the patients and the parents of the patients and the policymakers, both in Malta and the UK, are all very grateful for the service, and they really value the service and want to continue on in the future and see it as a good model that delivers high access to high quality care in a timely fashion. So you have to understand that some of the acute transfers happen literally within a matter of hours, and the relationships are so good and well established that you can sometimes transfer a patient from Malta to the UK almost more rapidly than you can from a district general hospital within the UK to one of these centres for excellence.
Professional mobility, it's important for cross-border healthcare. First, because it's a reality. Second, because we think actually it's going to happen even more now with the current state. So I think the important thing is to have a system that works well for the professional, but also for the patient, and that everybody can trust the system. The first step that we did a mapping exercise to understand how training works across the EU, and how licensing and registration works, how revalidation works, because revalidation is part of the training, which means that first you've done the training, but then in some countries they have decided that doctors have to revalidate their knowledge. And also we've looked at issues around redress. So what happens when something goes wrong? And in that case, we identified that in all these aspects, there were variations across Europe. And this can have an impact when healthcare professionals move, but in general also when patients move. It's difficult to describe the impact when you're only doing a descriptive analysis, which was our case. We looked at what is happening across 14 countries, what are the differences, but then you don't know much about what is the impact on the healthcare professional. So in order to overcome this barrier, what we did was to do a study in the UK, and what we wanted to do was to interview EU doctors that were working in the UK. It really highlights healthcare differences, the challenges that they face when they work in a new country, the challenges that they face when they want to go back, and most importantly, the cultural barriers that they can face working in a new country. Most of the people that we interviewed, they were very successful back in the countries, and actually they came to the UK because most of them wanted to learn new skills and have further training to be able to, if they decided to go to the country, to improve the situation in their own country.
Well, the thing is that we absolutely need to ascertain that professionals are competent in all fields of their work, and make sure that wherever they practice and wherever their patients come from, we maintain the highest degree of quality safety for European patients, but at the same time, with a view of harmonizing European guidelines, that the information provided to patients is fully transparent, that he knows what he is going to get wherever he goes to. The clinical guidelines are basically the baseline describing the various procedures that professionals should follow in different cases, in the different conditions that they would encounter with patients. And these are developed by the profession itself, often via professional organizations such as ours, the UEMS, or scientific societies, or even by the private sector sometimes, whenever there is really something specific with the developments they have produced or invented. I think the biggest challenge in terms of implementation of clinical guidelines is the acceptance or adoption and implementation at the national level, because this is where we can find a wide degree of variation, but which is often justified by the variation you have in terms of technology, investment, means, human resources, but also culture.
One of the major challenges is communication. Communication between a health professional who might refer a patient to someone in another country. And also, when a patient falls ill when they are abroad, when they return to their own country, the information should follow them back in a way that is understandable. Other issues arise, like, for example, where a patient is issued with a prescription and they need to have it dispensed in another country. Will the pharmacist recognise it? Will they understand the terminology of the medicines? Will they know that it has been legitimately prescribed? What do we do about patients or people who, perhaps older people who've retired to another country and spend part of the time in one country, often Southern Europe during the winter, and return home to their own country during the summer? There they may have long-term chronic diseases and they may be managed by health professionals in both countries. How do we make sure that that information flows effectively?
One of the challenges in long-term care in studying across borders is that there are many different systems. So there are some things that countries have in common. So, for example, in most countries that we studied, the private sector is dominant in providing long-term care. So what that means is you get a large number of private and independent providers providing care. And so there are some very specific challenges to how you manage quality and how you measure it. So because so much of long-term care isn't provided by governments, they have to set up a lot of regulatory processes and a lot of quality assurance processes to make sure that the quality of care that's delivered reaches an acceptable standard. And what we found is that countries have very different approaches to that. They have very different approaches to who looks at quality, how they look at quality, how often they look at quality, what information they then publish to the public. So we found that it was very difficult to compare countries. We found that the systems were set up very differently, and all of those things combined to make quite a complex picture. So what's interesting about long-term care is that in the EU directive on cross-border care, it's actually explicitly excluded. So all of the issues that are covered in the directive about healthcare actually don't apply to long-term care. There are some examples of people travelling between countries. So, for example, there are some care homes in Belgium where people from France travel because of different quality and different costs. So that's one small example. But generally, you don't see people travelling for long-term care. What you might find is some examples such as we discovered of people who have retired or moved to other countries who then need to seek long-term care. So what we found was for the small amount of people who do travel, part of the difficulty with long-term care is often within countries it's very difficult to know how you might access either funding or services themselves. So people in many countries find the whole trying to access long-term care very difficult and very challenging and very unclear. There are often different levels of eligibility to care, different levels of access. And what we found is in situations where people do travel, that can be, or have moved, that can be a huge barrier to seeking long-term care. And in fact, we looked at 3 areas across France, Italy and England where we asked social services and local authorities and healthcare professionals how they support people who have moved and who do find themselves in a new country. And it ranges. So in one area that we worked in, we found that there were a lot of what we've called retirement migrants, so people who've retired to a new country. And in that area, they received a lot of proactive care. So the authority in one country, where there was a high population of migrants, had very clear strategies for how they would find them, how they would support them. And that can range to a very low level of support in other countries. So if you imagine how difficult it might be to know how to seek long-term care, whether it be personal care or nursing care, and you magnify that, you magnify it with the language issues and new systems, then I think you can see just how difficult that might be.
ECAB has brought a degree of clarity to the debate on cross-border care. It has made us realise that often cross-border care has been presented as a solution in search of a problem. Cross-border care is not necessarily a good thing in its own right. We shouldn't be telling people that they should be going abroad when they neither need to nor want to. It's to allow them to move freely within Europe to get the treatment that they need, or to make sure that they remain healthy if they fall, or become healthy if they fall ill while abroad. But the idea that we should be promoting it as some sort of European market in healthcare really will serve no one's interests.
The healthcare sector it's an entirely national competence within the EU, so every member state does and can do what they see as is suitable for their population. So there's actually no reason to go for standardization at this level in the EU. The EU doesn't have any legal competence, and member states are very eager to keep their power and their authority in this area. It's a very sensitive area because, healthcare is something people, general population, care a lot about. I think one of the other protection mechanisms against patient mobility skyrocketing is that patients basically want to be treated at home, where they feel familiar with doctors and hospitals and the system. I doubt that people will ever start traveling all over the place for healthcare. It's just not what you want. If you are in pain or you have a disease, you want your family around you. You don't want to also have to think about the logistics of traveling and of maybe speaking a foreign language. Many Europeans don't travel at all to foreign countries, let alone if they're ill.
I think we need to be very careful when we think about the future of cross-border care. Cross-border care is only important in as far as it allows people to exercise their freedom of movement within Europe. Unfortunately, sometimes cross-border care is seen as something good in its own right. In other words, we want to encourage people to cross-border to get care. That's not the case. Most people want to be treated near home or where they fall ill, and that may possibly be abroad. The danger is that the agenda on cross-border care has to some extent been captured by those people who want to promote competition in healthcare. And because they've had difficulty promoting competition within the system in their own country, they look for competition from another country and raise the spectre of patients moving abroad in large numbers. Generally, patients do not want to travel abroad.
I think we can still say it's a niche phenomenon. I would say some 99% of healthcare gets delivered within home countries to people living there. So the 1% we're talking about are the border regions, are those that seek healthcare that doesn't exist at home because they have a very rare disease, because they are looking for something that fertility treatment or abortion, something outlawed at home, or because they are looking for more affordable care, so out-of-pocket payments for dental care, for example. So, but this remains the tip of the healthcare iceberg, really.